as plastic surgeons, I am a Botox user, I'm a Dysport user, I'm a Jeuveau user, and I use toxins for many different things. And one of the things that we've developed a practice in, not purposefully, but by necessity, is treatment of vaginismus. And vaginismus is a difficult process for women, especially young women. And it's usually primary. In other words, it's something that happens when you're young and results in spasm of the upper vaginal muscles. And almost everything I'm going to talk about today has to do with the word V. The problem is I'm seeing people now from all across the Midwest and even New York City have flown in for me to treat their vaginismus. And I'm finding more and more that people are misdiagnosed. So I'm going to separate and not talk about vaginismus for a second and talk about vulva, another V word, vulvodynia. And vulvodynia is pain at the opening or introitus of the vagina. And so we're going to talk about the idea of what it is we do and how we do it. And I'm going to talk about the diagnosis. And I'm not a gynecologist. I'm not trained, I'm not certified. And so I don't treat this, but I see a lot of young women that are coming to me for treatment for vaginismus that have vulvodynia. And vulvodynia is different. And so there are different causes and reasons for people to have V-related pain. And so the first treatment or first part of this is a good examination by a good and qualified gynecologist. And they won't be able to, and because of credentialing and stuff like that, be able to inject Botox. But let's talk about it first. So a good, competent gynecologist, if you come to them with pain in the girl area, will say, let's do a physical exam. And the first part of what we find is that inside the labia majora, the hair-bearing area, and then the labia minora, the area that does not have any hair on it, the inner lips as people refer to it. And the area between there and the hymenal ring is an area that's just millimeters in a circle at the introitus. And that area is called the vestibule. And there is a process called vestibulitis, another V word. And the vestibule in very many women is a ring of fire. And it is hot to touch. And a qualified gynecologist will take a moistened Q-tip and just push on the vestibule all around, and they can map where the introitus and the vestibule has areas of pain. I see a lot of young women that come to me with pain at the initiation of penetration that have vestibulitis, and the treatment is not toxin. Now, the treatment classically has been surgical to do a vestibulectomy, to remove the entire ring or the area which is hot on the Q-tip test. The problem is the circular scar gets tighter over time, and there is an enzyme called heparinase. And there's a medication out there now that in a randomized prospective controlled study, it involves injecting yourself daily for a couple months with a medicine called enoxaparin or Lovenox. But my patients have been willing to do that, but I really don't want to be treating patients with vestibulitis because it's just outside my field. But if you come to me and it's obvious from your clinical notes that you've not been adequately tested, you really need to be adequately tested for vestibulitis before we talk about treating you for vaginismus. So vestibulitis can either be treated by vestibulectomy or by treatment with Lovenox. And women get a very significant 70% response to that area being treated with Lovenox. Let's say all of that's been treated, and very successfully so. Or been evaluated, and that's not it. The pain is deeper. And so when women discuss with me their idea of their vaginismus, they're able to have penetration and whether it's with a dilator or fingers or with a penis, they're able to get penetration, but once it's partway in, halfway in, that's when they spasm, and that is vaginismus. And we're able to tell, and for some women, they're able to deal with this with physical therapy, with dilators, with biofeedback, health therapy, mental health therapy. They're able to get past that. But for some women, they're just not able to do that. And there are muscles in the back wall of the vagina that just go into spasm after halfway through penetration has occurred. And that's where we come into play. And that's where we do something by, I don't even try doing a physical exam in the office. This is something people have to have been adequately evaluated by a gynecologist before they come and see me. And so if they've got a certified diagnosis of vaginismus, we take them to the operating room. We have them go to sleep. And while they're asleep, their muscles are still in spasm. We don't paralyze them in the anesthesia department. We have them still breathing on their own, but they're asleep. I go in and I can actually feel with my fingers. I can feel those muscles. They feel like a short cigar. It is so easily palpable that I can actually feel it. I go right inside the muscle and I inject toxin, Botox. And it's an off-label use of Botox, like many uses of Botox, and I inject directly into the muscle, which feels hard. The toxin doesn't work for 3 days. And so I then, after I'm done injecting the toxin, I put they bring their own dilators, I put the largest dilator in. We leave it in. We have them wake up with the dilator in, we leave it in for half an hour or so after surgery, and we have them go home and start using the smaller dilators. And for 2 or 3 days, we wait for the muscles to relax. And in people with a certified diagnosis of vaginismus, we found that we're able to treat this typically one time, break the cycle of spasm, and they're then able to use their vagina again. And typically we've not had to retreat patients who have classic and straightforward vaginismus by use of Botox. Again, it's done with a patient completely asleep in an operating room, and it really requires that I work with whoever your gynecologist is, and your gynecologist has done a good evaluation to deal with what is the cause of vulvodynia. Is it vestibulitis or is it vaginismus?